program. Over to you, Yogesh.
Thank you so much, Hitesh, for the introduction. It's an honor to be on your channel. I'm sure many audiences have loved all the lectures in your channel, and I hope you carry on doing this because it's so much beneficial for the orthopedic community all over the world. I'm Yogesh Joshi. I'm one of the consultants, knee consultant at Wrexham Hospital, and I live in North Wales, one of the beautiful part of UK. And if you are interested in knee surgeries or having observerships, you're more than welcome to join us. Today, we are going to talk about total knee replacement surgeries. Now, I'm going to give tips and tricks about total knee replacement surgeries. It's mainly how we are going to anticipate the problems in difficult knee replacement surgeries and how we are going to solve those issues. Mainly, we will be talking about technical goals, different approaches in brief, bony cuts and balancing, addressing any balancing issues through soft tissue releases, and avoiding malalignment. For this lecture purposes, we are going to look at mechanical alignment. I'm not going to speak about the other alignments that have recently been talked about. Although, you know, if that's one of the interests, I can do another presentation on different alignments of knee as well. So the technical goals of mechanical alignment knee is restore the mechanical alignment of the lower limb, restore the joint line, balance the ligaments, and to gain the normal Q angle for normal patellofemoral tracking. Firstly, we need to look at the positioning. So positioning is critical in knee replacement surgeries. So we need a side support to hold the thigh in place. We need a foot support so that the foot is bent in more than 90 degrees of flexion. So when we sublux the tibia, it's easier to do so. Some people might put 2-foot support so that the angle of the knee flexion can be changed intraoperatively. Tourniquet, me personally use a tourniquet, but nowadays there are quite a few papers suggesting that tourniquet use might hamper early rehabilitation, but it's a surgeon's choice at the moment. Apart from positioning, the lighting is quite important, especially in theater, so that intraoperatively we are not struggling to see what we need to see. So typically we put one at the lower end of the table and one light over the top of the table so that we can see and visualize the knee appropriately during the surgery. This is the foot support that I use, but there are various foot supports that are available. And you can have a changing foot support where you can change the flexion extension of the knee as well intraoperatively. Incisions. Now, incisions are quite important, especially if you're operating on a knee which has previously been operated upon. The skin incision, if there are multiple incisions, always use the lateral based incision because the blood supply to the anterior part of the knee comes from the medial side. If you're putting more incisions and looking at the incisions, always keep a bridge of about 6 centimeters between the two incisions. It's not always possible, but if possible, please do so because that will critically hamper the blood supply of the anterior part of the knee. I typically avoid the tibial tuberosity, as if the incision goes on the tibial tuberosity, kneeling might be an issue in some of our patients. The workhorse of knee replacement is the medial parapatellar approach. It's the most commonly used approach. Most of the people are familiar with it and has got excellent exposure even in challenging cases. There are some disadvantages, but they're not huge, especially in related to the patellar release. So if you do a lateral release with a medial parapatellar approach, there is a small risk that it can jeopardize the blood supply to the patella. The lateral parapatellar approach is sometimes used in severe valgus knees, and it allows to access the lateral side of the knee. It is easier to release the lateral soft tissues through this approach, but it's technically quite demanding. And the medial patellar eversion is quite difficult as well. The other thing we need to note that the tibial rotation to gauge it is quite difficult in lateral parapatellar approach. The other approach that people are using is the Subvastus approach. It has got advantages of accelerated rehab. I use it for my unicompartmental knee replacement surgeries. It has got improved patellar tracking. The disadvantages is less extensile and is difficult in obese, as well as very tall persons and patients with flexion contractures as well. The subvastus approach is the in which the vastus medialis is lifted off the intermuscular septum. The advantages of that is early rehabilitation as the cord is intact and preserved vascularity to the patella. The disadvantages is it's quite less extensive. So if you need to do more work on the lateral side, it's quite difficult. There are various extensile approaches, especially quad snip, V-wide turn down, and tibial tubercle osteotomy. They're very, very rarely used in primary knee settings. Although, if there is an ankylosed knee that needs to be replaced, then probably this is when these kind of approaches are used. So then comes the preparation of the femur. So we do the entry point. The entry point is slightly medial to the midpoint of the condylar width, and that's because the axis of the femur exit on the medial aspect of the knee itself. If you look here, that's the anatomical axis, and that is the mechanical axis of the femur. The angle between the two axes differ in different people. Most commonly, it's between 5 to 7 degrees. In taller people, it's lesser, and shorter people, it's more. So we need to adjust that accordingly. Also, if you look at this picture here, you can see how the medial side is taken more off than the lateral side, and that's to do with the mechanical alignment of the femur itself. Also, at the same time, we need to look at the flexion deformity of the knee. If there is quite a bit of fixed flexion deformity, then we can take excess of distal femur and increase the resection of the distal femur to accommodate the fixed flexion deformity. Usually, the distal femoral cut is taken according to the thickness of the femoral component. The next step is the anterior and posterior, as well as chamfer cuts of the distal femur. The anteroposterior cut of the femur is quite important, and it's quite important to get the rotation of the distal femur correct as well. The worry, obviously, for an anteroposterior cut is the notching of the anterior femoral cortex. Always reference the anterior cut over the anterolateral aspect of the femur, because if you do notch, there is a risk of increased periprosthetic fracture. It rarely requires bypassing the notch area, and always remember the grand piano sign. If you look here, that's the grand piano sign. That's the standard anterior cut. That's how it should look normally. If it's externally rotated, you will get exaggerated grand piano sign. And if it's internally rotated, you will get a different kind of shape itself. Be aware that different people have different morphology, especially in people with trochlear dysplasias, where this might not be the same case. Looking at the flexion and rotation of the distal femur, if you look, in my practice, I always practice measure rejection technique, and hence we are looking at the rotation in reference to the posterior condyles as well as the white sides line. And as we know, that the relation between the white side line as well as trans epicondylar axis is perpendicular. We know that the joint line obliquity is about 3 degrees, and that's how we create an external femoral rotation to accommodate this. It achieves 3 things. One is it achieves a rectangular flexion gap. It also helps in patellofemoral tracking, and it helps with the condylar reference itself. And we want to end up having a rectangular gap in the end. We achieve this with a distal femoral jig, and you can see here we have to rotate it such that it matches the right side line as well as transepicondylar axis. At the same time, have a look at the referencing point. It has to be put on the anterolateral aspect of the femur so that there is no notching of the femur. So there are 2 things going on at one time. One is the sizing as well as the rotation of the distal femoral anteroposterior femoral cut. If you look, there are 2 types of instruments that are available. One is called an anterior referencing jig, in which the notching is very less likely, and you take more or less of the posterior femoral condyle to accommodate the size of the femur. If you look at the posterior referencing guide, the posterior cut is constant, whereas the anterior cut determines the size of the femur. So we have to be careful as to, or we have to be sure what we are going to use. In my practice, I use posterior referencing jig. At the same time, the rotation can be adjusted on this jig. All patients don't have standard 3 degrees of external rotation, and they may slightly vary anatomically. So you need to have that option as well to change the rotation at the same time. Coming to the tibial cut, obviously the tibial anatomical axis and the mechanical axis in most of the people are the same. So the tibial cut has to be done at 0 degrees. So we cut at perpendicular to mechanical alignment of the tibia, and we can use either intra or extramedullary guide to do this. In cases of malalignment of the tibia, we cut perpendicular to the mechanical axis and not the anatomical axis. And we have to measure it thrice and cut once. You have to look at all the different axes where you're going to make the cut for. So first of all, we have to see whether there is the varus or valgus alignment. So you put the jig onto the proximal femur and look at the AP axis of the tibia. The AP axis is over the medial border of the lateral tibial plateau. That's how you determine the axis of the tibia. Then you adjust the varus and valgus alignment of the tibia by changing the jig position so that it's center over the ankle. At the same time, you look at the slope of the tibia, and you do this with eyeballing to see as the slope varies in different people. I would caution on the finger technique where you put 3 or 2 fingers in front of the tibia and between the jig and the tibia, because all people have different tibial slope. We naturally goes for a natural slope rather than a fixed slope. If you are PCL substituting, make sure you don't over cut the tibia in the posterior direction. Otherwise, there will be a flexion laxity. The depth of rejection is then set after checking all the 3 axes. Usually, we take 2 millimeters from the most worn out area. This is if it's bone on bone and quite eburnated bone. If we are doing it for mild deformity and mild arthritis, then we will take 10 off from the lateral side in a varus knee or 10 off from the medial side in a valgus knee. Once we have dealt with the tibia and the femur, we have sorted the alignment at this moment. The next step would be to balance this knee, and this is an art. The balancing is started in extension first, and then once the extension gaps are symmetric and rectangular, then we look at the flexion gap. The aim is to have flexion and extension symmetric rectangular gaps. If they are asymmetric, that could be because of two reasons. One is for the bony cut. The tibia might be cut in varus or valgus, or the soft tissue. So if there are pre-existing deformity and contractures in form of fixed flexion deformity, recurvatum deformity, varus or valgus deformity, you tend to do the soft tissue releases. While balancing the extension gap, if it's quite small, then you can resect excess of distal femur, or you can release the posterior capsule. If there is tightness in flexion, you can either increase the slope of the tibia, or you could recess the PCL. Looking at the medial side, if there is a varus knee, the medial side will be tight, and it will cause asymmetrical gap on the medial side. The first thing you take out is the osteophytes. Those are the most deforming cause of the tightness of the MCL, as the MCL is over or tenting over the osteophytes. Once you get rid of the osteophyte and still the gap is asymmetric, you do sequential release. Firstly, you release the deep MCL. That is one of the ligaments that you release as a part of the medial parapatellar approach. You release the deep MCL to the mid-axial point as a part of the release during the approach. But if it's still asymmetric, you can release it further posteriorly. The next step is to have a look at the posteromedial corner. There is a tendon of the semimembranosus here and the posteromedial capsule here, along with the POL. This can be released at the same time. If still, you can see here at the diagrammatic representation of the semimembranosus tendon, and you can release it subperiosteally if the gap is asymmetric. The superficial MCL has got two parts. One is anterior and posterior. The anterior part is, if you release the anterior part, it relaxes the gap in flexion. If you release the posterior MCL, it relaxes the gap in extension. So depending on what is tight, you can release the superficial MCL after releasing the posteromedial corner. Once you do this, most of the deformities get corrected. And even if they don't get corrected, there are further releases you could do. You can release the pes censorinus. You can do a subtraction osteotomy of the medial tibial plateau, and that will shorten the tibial plate itself, but it will relax the MCL and straighten or equalize the flexion and the extension gaps. You can also do pie-crusting of the MCL as a last resort. Looking at the lateral structures of the knee, we have got the iliotibial band, which is a deforming force in extension in a valgus knee. At the same time, in extension, the LCL is tight, as well as the posterolateral corner is tight. In flexion, the LCL and the posterolateral capsule is relaxed, whereas the popliteus is tight. So if you want to correct a valgus deformity by soft tissue releases, the first thing you do is pie-crusting of the iliotibial band. You do this in extension initially, and once the extension gap is equal, then you think about checking it in the flexion. If the gap is asymmetric, even after pie-crusting of the iliotibial band, you then release the posterolateral capsule. You can feel the thickened posterolateral capsule at the back of the knee. The valgus knee is a disease of flexion. So always check the gaps in flexion after releases in extension. If it's tight in flexion as well, you can release the PCL or recess the PCL, or you can release the popliteus tendon at the same time. Hopefully this should get the deformity corrected. If not, then there are further releases that could be done. Going ahead, once the gaps are balanced, at this time, you're going to try and prepare the tibia. Preparation of the tibia is quite important, especially getting the tibial component rotation right. We should not internally rotate the tibia, as this increases the Q angle and causes quite a lot of patellofemoral issues postoperatively. There are various landmarks you could use to gain the tibial rotation right. First, we look at the medial third of the tibia, and we can orient our tibial component with this landmark. The other landmark is just going to the anteromedial curvature of the tibia and putting our component at the same curvature as that anteromedial tibia. The third one is the transtibial axis, whereas the medial and lateral tibial axis and the AP axis is drawn perpendicular to the mediolateral axis, and the component is placed in that orientation accordingly. The fourth landmark is what we call as Akagi's line, which arises from the insertion of the PCL and goes to the medial border of the patellar tendon. This is the most commonly used landmark. Nowadays, there are implants that are anatomical and asymmetrical, which are more, which gives more coverage and proper rotation of the tibia and avoiding internal rotation of the tibial component. As we know, if there is the tibial component is well positioned, the patellar tracking will be much better. Whereas if we internally rotate the tibia, there will be excessive forces on the patella, and it will try and subluxate or can lead to increased pressure over the patellofemoral joint and can lead to post-operative pain as well as discomfort. Looking at the patellofemoral alignment, that's the next step of the surgery. We have to maintain the Q angle, and the Q angle is increased by internal rotation of the femoral component, medializing of the femoral component, internally rotating the tibial component, and lateralizing the patellar button. So all these steps should be avoided to make sure that there is no patellofemoral problems post-operatively. When we resect the patella, make sure we restore the composite thickness. So whatever we cut on the patellar bone, we need to substitute it with the patellar button. It has to be a symmetric resection. Always remove a part of the lateral facet, because some part of the lateral facet will articulate with the metal femoral component and will cause what we call as the retinacular pain. Always check the tracking of the patella. If the tracking of the patella is not right, always try and release the lateral side of the patella. The way to do that is by subperiosteal stripping of the lateral retinaculum over the anterior aspect of the patella. Alternatively, you can go through the retinaculum as well. Following that, we are ready for cementation. Make sure that you have got clean, dry bone surfaces. If there is blood on the surfaces, that will reduce the binding property of the cement and will lead to early debonding. Finger pressurize the cement to the bone. Always coat the implant so that there is enough cement to integrate to the bone, and avoid putting cement over the posterior femoral condyle, as if the component insertion is done, the cement will slip into the posterior recess, and it's quite difficult to take it out. Thank you very much.
Thank you, Yogesh, for that brilliant and crisp presentation. A couple of questions, Yogesh.
Yeah.
Just it's a recap. So what is the sequence of your Varus release? What exactly do you do? I mean, you've said about it in detail, but just to recap for the benefit of the audience.
Yeah.
Like 1, 2, 3, 4, exactly.
Yeah. So
in that order.
Yeah. So in a Varus knee, first of all, once we do an approach, we have to release the deep MCL as a part of approach. You release the deep MCL to the mid-axial line, nothing further than that. Then you assess the gaps. If the medial gap is quite tight, the first thing you do is to release the deep MCL all the way to the back. Then you take all the osteophytes on the medial side, especially over the femoral side, because when you flex the knee, you will see the osteophytes going beneath the MCL all the way posteriorly. So once you take those osteophyte out, suddenly the MCL will be quite stretched out. You reassess the gap. If it's still tight, then you release the POL, which is the posteromedial corner of the knee. At the same time, you can release the insertion part. You can go subperiosteally over the insertion part of the semimembranosus at that time. If all these procedures don't lax or doesn't make the gap symmetrical, that's when you start releasing the superficial MCL. The superficial MCL has got two parts, the anterior and the posterior. It's tight. The anterior part is quite tight in extension, and the posterior part is tight in flexion. So you have a look. Firstly, we have to look at the extension. If the extension is well balanced, then you look at the flexion. If it's tight, then you can selectively release the posterior part of the superficial MCL. All you need to do is to put an osteotome and just slide it down over the distal part of the superficial MCL, and that should release it. If all these procedures don't correct, which is very unusual, this releases should correct any varus deformity. If it's not possible to release more, then obviously then you can do what we call as a subtraction osteotomy of the medial tibial plateau, wherein you take a part of the tibial plateau away over the medial side, and that will relax the MCL a little bit more. You have to be very cautious when you do that, because if you take excessive off, it will lead to more opening of the medial side and tighten lateral side. Then you may have to do a compensatory release on the lateral side for that. So just be cautious on those terms. But most deformities, even severe deformities, will, if you follow this sequence, should get corrected.
Thank you, Yogesh, for that. The other question is regarding the tibial jig placement. For example, we use an extramedullary jig, right, commonly?
Yes.
And what is a landmark that you place on the ankle so that you get, parallel to the mechanical axis?
It's the tibialis anterior tendon. So if you palpate the tibialis anterior tendon and mark it beforehand on the drape itself, then you can just position your rod at that position.
Okay, thank you for that. And just one last question before we wind up the session. You mentioned about placement of the cement, right? So on the femoral side prosthesis, where do you apply cement, and what about the tibial side? The prosthesis before implantation.
On the prosthesis on the femur, usually we put it on. I put it on the posterior condyle itself, because I can't put it on the bone, on the posterior condyles of the femur. So you put it on the posterior condyles of the femur on the component and beneath the trochlea. So those are the parts that I put on the cement before insertion the component, and that causes more bonding. So once you put cement on the tibial and the femoral bony surface and the component, there is something called a cement on cement bonding, and that gives extra kind of bonding to your implant.
And on the tibial side, you can put it throughout, right, on the undersurface?
That's correct, yeah.
Okay, only on the femoral side, you put it on the posterior condyle as well as on the trochlea, right?
On the trochlea.
Okay. Thank you, Yogesh. I think that's all the questions that we have for this session. Fantastic lecture as usual. And I'm sure this lecture is going to benefit a lot of people all over the world. Thank you so much for joining in.
Well, thank you so much, Hitesh.